Thank you everybody for coming. Usually I see some of my patients, they don't get enough of me, so they like to show up again for more stuff. Yeah, there's right here. So anyway, I want to talk a little bit about some minimally invasive spine surgery today. It's my professional interest. It's certainly something I like talking about. The talk, you have little bits and pieces of it in there. I truncated it a little bit so that we could have a little bit of time to answer some questions between the talk on some of this and the spine model. Hopefully we can educate you guys on some of the problems in pathology and in your back and so forth. So when we talk about surgery, it's all about your quality of life. Most of the stuff I do is elective surgery. You don't have to have it. You do it because your life is not good, because you suffer from pain or some type of disability. And what is that pain doing? It's preventing you from doing some things that you want to do. Maybe it's something simple like spending time with your grandchildren. Maybe it's other things like you just want to shovel some snow or do some housework or even just do the dishes. I have a lot of patients, all they want to do is cook a meal, and they can't do that. Other people, maybe they just want to go on vacation. I got a lot of cruisers in my practice. They just want to go on cruises. And some of them have so much pain, they come in, they tell me, we didn't even leave the boat. That's not what anybody wants out of their life. You shouldn't pay several $1,000s to never leave the boat because you hurt so much. As far as an introduction, we're going to talk a little bit about the anatomy of the spine, primarily the lumbar spine. That's what most people suffer from. It's probably better than 80% of my practice. We'll talk about some of the pathology. You've probably heard about some of these saying spinal stenosis, disc herniations, this long word, spondylolisthesis. And then we'll talk about some alternative treatment options. Many of you have probably already had some of the non-operative options, and we'll go over those. And that would include the minimally invasive spine surgery, which is my professional interest, and then something called an Inter-Spinous process device, which maybe if you had a back problem 5 or 8 years ago, they would have recommended something called the X-stop. That's what that is. I'm going to show you why that worked, just more from a historical perspective. I think it's sort of interesting. So here's the spine, right, when it's out of the body. Cervical, thoracic, and lumbar spine. Most people complain about the problems here in the low back, and we'll focus again our talk on that. There are 5 lumbar vertebrae labeled 1 through 5. So if you have an L1-2 problem, it's these top vertebrae. This is L5, this is S1. So this is L5 and S1. This is a side view, if someone was taking a picture through the side, and this is looking at you back to front. This is what it would look like. This is your sacrum. And this is an actual vertebra. This is looking at it from the side, and this is actually looking from the top down. So if we look at this again, is that side view. That's what you're looking at there. And then this is the vertebra top view. This would be looking at it like that, okay? So you see, and the reason I have this here is it's all about these holes, okay? We see this hole here. All of the nerves, okay, they start in your brain and they go down a tube. The brain terminates as the spinal cord. The spinal cord will go down this central hole. That's called your spinal canal. And then eventually the spinal cord stops, and then it's just a bunch of stringy nerves that go down into your legs, okay? So we want this hole to be very big. We want lots of room for the nerves. We're all familiar with the term pinched nerve. It's because something is in that hole. Maybe it's a disc herniation or a bone spur or a tumor, okay? The other hole we're concerned about is this hole, this one in between here. That's called the foramen. We'll go over this many times because it's important for you to understand. It's all about these holes and how big these holes are, okay? Looking at other things. Again, this is a side view of the spine. You see that center hole with all the nerves that come down from the brain, and then these side holes as the nerve exits, okay? Look at the holes here. And again, these holes are called the foramen, right? The foramen intervertebral. That nerve's coming out of here. Look at the proximity of this hole to this disc. The disc is what is in between those bones. It's the shock absorber in between these bones. that is mobile part and it allows for motion, okay? And if this disc herniates, what that means is some of this cushion is now touching one of those nerves, and now the hole is smaller. And that means the nerve is being pinched, right? So it's all about these holes. It's also about bone spurs. There are these small joints back here called facet joints. Maybe you guys have heard this. Maybe you've had rhizotomies, or some doctor has, quote, burned the nerves. They're usually burning the nerves to these small joints in the back. Those are called facet joints. But if I get a bone spur, because I develop arthritis off this, it's going to touch that nerve and narrow the hole. Does that make sense? Yeah. So, definitions. Everybody comes in, they say they have sciatica. We don't use the word sciatica in spine surgery. We use the term radiculopathy, but we're talking about the same thing. Radicular pain means pain that's just shooting down the leg. You call it sciatica, we call it radiculopathy, okay? And then stenosis. Everybody's got that. Everybody's got stenosis on their MRI. All stenosis means is pinching. It's a simple word for pinching. So if you have pinching, you have stenosis. We talked about those holes. So if something's in the hole, maybe it's bone spurs, maybe it's a ligament that's too big because it's worn out, maybe it's a disc herniation, maybe it's a tumor, or whatever it is, all of that causes stenosis. So somebody said to me today in the office, well, I have a herniation, but what about the stenosis? It's the same thing. The herniation is causing pinching. Pinching is the stenosis. Very simple. Big words, silly words. That's what it means, okay? So the aging spine. This is what most of the problems that I deal with are patients whose spine simply is just getting old. And I use this dog here and all of its wrinkles because one of my mentors at Georgetown, when I was in a room with him and he was examining a patient, and the patient said, "Doctor, why do I have this stenosis? Why do I have these bone spurs?" And he said, "You see those wrinkles on your face? These are the wrinkles on your spine." And now I use that term in my office. I stole that from him. That's not a Wagener original, okay? I use that term because it's true. And I say, you earned all those bone spurs. You earned all those wrinkles, whether it's from having a tough job or a tough life or maybe parents that just passed it down from you, but you earned it. But what happens in the spine as we get older, what happens is these discs, they're not so tall anymore. They degenerate. They do that. The first thing that happens is you lose water. Okay? Then there's a change in chemical composition. It's not the same cartilage in there. It's not the same stuff. So they start to shrink. That's why you get shorter. Okay? And then you lose the disc height, you lose some cartilage. What happens, and this is a little bit complicated, but bear with me, there are joints in the front, and at the same level there are joints in the back. If I lose the joint in the front, there's more pressure on the joints in the back because they all work together. Okay? So if I lose this, then all of a sudden these facet joints, we talked about those before, those will start to take up more of the stress. Okay? Then you lose the cartilage, then you get abnormal motion, then extra bone forms. Okay? People always talk about bone spurs, and you're not used to hearing about them in the back. But most of you can look down at your hands as we get older, depending on genetics and occupation and trauma and all sorts of other things. This is what happens. Okay? You lose cartilage, you get abnormal motion, and then your body does this amazing thing. It forms bone to stiffen up the joint so that you can keep on using it. These bone spurs are fine in the hand. No one cares about them. They don't look good. You can't get your rings off, but it doesn't pinch nerves. In the spine, imagine if we had those same bone spurs right here, plugging a hole. Then we're going to get leg pain. And that's what happens. We're all used to seeing the knobby knees. I saw a patient today, true story. He was asking about his arthritis. What do you mean I have arthritis? And when his knees were showing, and I said to his wife, "You didn't marry those knees, did you?" She goes, "I've been married for 54 years. No, I did not. They looked different. They were knobby knees. They were full of bone spurs. Why? You lose cartilage, abnormal motion. The body doesn't like the abnormal motion. It forms bone. So here's this spinal degenerative cascade that we all know about, and it's either going to occur at the disc or at the facet joints, right? We talked about the disc being connected to the facet joints, that front-back motion segment of the spine. And you either will have a facet joint problem or a disc problem, but it all leads to this here, which is age-related changes, dysfunction, herniation, instability, nerve trapment because you're getting clogged with those holes, and then stenosis leads to poor quality of life. And here's this time lapse here of this lady. She's walking upright, and then she has some problems. She needs to use the shopping cart, and now she's just stuck in the chair because that's the only place that feels good when she's sitting in the chair. That may be you, maybe not. Some people, there are other problems where you don't like to sit, like some disc herniations. You hate to sit. Here's another picture of the spine. Again, this is a cross-section. If someone just took a real spine and just cut it right in half, you can see these are big, healthy discs. These are what some of your discs look like. Maybe what mine looks like. Okay? Degenerative. We're shrinking. It's tough to stop the process. This is spondylolisthesis. Some of you, I am sure, suffer from spondylolisthesis. And what that means, what that is one vertebra has moved relative to the other one. Okay? It is slipped. Okay? So spondy means vertebra and listhesis means slippage. So if the vertebra has slipped. So if I have all these holes, okay, you can see that here, by the way. If I have a hole, even the major tube that goes down at L4 and another tube of L5, and one slips relative to the other one, the hole gets smaller. You agree? It's true, I promise. That's what happens. And then you get leg pain. You get those symptoms of stenosis or radiculopathy. And you can see that here. You can see one bone slipping relative to the other one. It gets this kink. All the nerves are going down this tube, and you get a kink there. And that hurts. Again, all about the holes. Here's another picture. Nice, beautiful spine. I wish mine looked like this. Look how big these discs are. Everybody would love to have a spine like this. In this area here, this is the end of the spinal cord. These are all the nerves. God was very kind to this person, gave him a huge hole. We're all born with different size holes, okay? The tube for our nerves. Some people are born with really big ones. This person, very blessed with how big this hole is, okay? All those nerves are happy. But if something were to come from here and go into this area where the nerves are, it's going to hurt. This is a less fortunate person, right? Where this is being clogged by the bone spurs and herniations and so forth. Does that make sense? Yes. And if we take that same spine and we cut them up, these are MRI pictures, by the way, okay? When we look at MRIs as physicians, we look at pictures cutting you up this way, and we look at pictures cutting you up like this way, like a loaf of bread. These are called axial images. And this, we're looking at it like this. And in our minds as surgeons and physicians, we piece together these two sets of 2D images, two-dimensional images, to make a three-dimensional image in our mind. And this is looking at here, and you can see that big tube. These are happy nerves. That's what I call them in the office. Nerves just floating around in fluid. That fluid is good. We want a lot of spinal fluid. These are happy nerves. But when you get arthritis, these joints here in the back, the facet joints, they start forming bone spurs, and these are less happy nerves. Does that make sense? For all the reasons that we talked about. This is a CAT scan. Some of you may have had a CAT scan before. I get a lot of CAT scans. And you can see this is that tube there. And here is the tube. Look at these big bone spurs here. Okay? Those bone spurs are not benign like the ones on your hand. They're touching things. Okay? So what does it all mean? The sciatica, stenosis, spondylolisthesis, pinched nerves, and bone spurs. It leads to arm pain or leg pain depending on where the stenosis is, disability and dysfunction, and it disrupts your life. Okay? Now we're going to talk a little bit about the disc herniation. stenosis and spondylolisthesis, and a little bit more as far as the clinical presentation. Here's stenosis. Here's my friend with stenosis. I saw about 15 people that look just like this today. It's the same story. Over 60 years old. It didn't start one day. It started over the course of many days or months or years, and then they just start walking more and more like this. And the wife comes in and they says, make him stand up straight. I always tell him he's not standing up straight. It's always the wives. I'm not really sure, but they're always critical, right? Stand up straight. And I have to tell him he can't. I'm going to tell you why he can't, but he can't stand up straight. Okay? They usually have back pain with some buttock pain or some leg pain, morning stiffness and aching related to that, arthritis. It feels better if they lean forward. It's worse if you lean back, okay? And then there's that shopping cart sign. They can't walk very far if they have to walk upright, but if they get in the grocery store and they grab that cart, they can go, okay? And there are reasons for all this, and we'll go over that. Degenerative spondylolisthesis is a condition, is a deformity of the spine, but it causes stenosis. So spondylolisthesis causes stenosis. And you can see all those tube of nerves, and this is where the problem is going to be, right there. That's where the nerves are being pinched. And these people, they're typically a little bit younger. There's a predisposition for women. I operate on far more women than men for this problem. And they might be a little heavier, and it almost always is between L4 and L5. Almost always, degenerative spondylolisthesis. When we do a history and physical in the office, we'll figure out that localized pain area. They usually don't like to be an extension. This is what we call extension. This is flexion. They usually have a forward flex posture. It's important to do a detailed neurologic exam to make sure that everything works right. And then vascular exam. People, they wear out their backs, but they also wear out their blood vessels. And the blood vessels bring blood, oxygen to the legs. So in some patients, it seems like they look like they have stenosis. They can't walk far, their legs hurt. But in point of fact, they really have a blood vessel problem. They're not getting enough oxygen to the bloods because the blood vessels are stenotic. They're pinched. So we got to make sure in some people that there is not two things going on, okay? Because a lot of times, older folks, they have stenosis in the low back, but they also can have peripheral or vascular disease. And you wouldn't want to operate on a back if the real problem was coming at the level of the blood vessel, because you simply weren't getting enough oxygen to the blood vessels. We also do a gait evaluation. The other thing is hip osteoarthritis. A lot of times patients will complain they can't walk far and they have this buttock pain. Sometimes it radiates even into their thigh, and they'll have stenosis or pinching in the low back or in the low back on MRI. And the whole time it was maybe they had some pinching in the back, but the real problem was a hip osteoarthritis. I can't tell you how many times I've seen someone who had a low back operation, but they needed a hip problem, or vice versa. They had their hip replaced. In point of fact, it was coming from their back all the time. The reality is, when you get to be 65 years old, some of you are over 65, you don't have one problem, right? The days of one problem, those are long gone. Those happened decades ago. When you're 30, you got one problem. When you're 60 or 70, you got 10, okay? And there might be a primary problem, but we just kind of chip away at. You're a project. You guys keep the lights on here at Coordinated Health. That's what I say, okay? But all these parts, they wear out. We're not meant to live this long, right? We're not meant to live to 70 and 80 years old. I never dreamed that I would be operating on 80-year-old people. We weren't in my training 10 or 15 years ago. 80-year-olds weren't getting back operations. You'd be surprised how many 80-year-olds. Every week we operate on an 80-year-old because they want to get around. They got stuff to do, right? So the studies we get, you'll get some x-rays in the office if you haven't had them. Some people get CAT scans to evaluate for some of this pinching and stenosis, an MRI, and sometimes they'll come in with what's called EMGs or nerve conduction velocity tests to help pinpoint where the pathology is. We looked at those MRIs before. Again, you can see this is where the nerves are, major problem right here, and a little bit here, and a little bit here. That's stenosis. That's what it looks like on an MRI. MRI looks at the soft tissues more than it looks at the bone. Almost everybody wants an MRI if they can, and those are those axial cuts we looked at before, again, stenosis. The natural history. What that means is, what if we did nothing? We just took a bunch of patients and we followed them with spinal stenosis. What would happen? Would they get worse? Would they get better? Would they end up in a wheelchair, as some doctors suggest? And the reality is, most don't get worse, most don't get better. They just stay the same. Okay? I guess that's good news, right? If you're okay with how you're living. But most don't get worse. Everybody's worried that they're going to be in a wheelchair or something like that. I don't get excited about stuff like that for your standard run-of-the-mill stenosis. The reality is, most don't get worse. Okay? You're not going to get better, but you're not going to get worse. What about a disc herniation? This is typically a younger crowd of people. Okay, it can be. We've seen it. I think we did a disc herniation on someone in their 80s. But generally, 80-year-olds don't have discs like a 20-year-old. They don't have those big juicy discs like we saw earlier. They have degenerated discs. They don't have this watery, gelatinous disc. So they don't get disc herniations. They get the bone spurs and things like that. So usually it's a 20 to 40-year-old. Usually they just wake up and there it is. It's God's gift for you for the day. And it can present as back pain, but it's primarily leg pain. You can see this disc coming in and touching these nerves. Generally there's not a problem with bowel and bladder function, but for an enormous disc herniation, you can have a problem with that. Most of them like to stand. That's my experience. They hate to sit. A true hot disc, you know right away, because you walk in the room and they're standing in the corner. Even if they have to wait for me for quite some time, they're standing. Okay, it's not because they're bored. They don't want to sit. And sometimes if they cough or sneeze, it can cause that lightning bolt type of pain in their leg. And again, here's another picture of that MRI. You guys are going to be experts. Look at these happy discs here, all full of water, this kind of bright signal. And look at this big disc. This is a very, very unhappy person, I promise you. And they may come in like this. They don't want to be towards the side of their pain. They may have some numbness or weakness. And we got to work those up with an X-ray and an MRI. Another example of a disc herniation. This is that axial cut, and you can see that clear-cut disc herniation there. The treatment for all of this, general stuff, we almost always, unless there's a reason to operate, start you out with anti-inflammatories or something like that. Sometimes you'll take oral steroids. That's 6 pills, 5 pills, 4 pills. Many of you have probably been out on that before. We like to send people for therapy, for stretching, conditioning, strengthening, and posture. Sometimes we give people braces. We'll send you to physical therapy for what's called the TENS units and electrical stimulation units. Sometimes that can be helpful. We modify your activity. If you have a real bad disc herniation, I shut you down. Don't have you pick up anything more than 5 or 10 pounds if it's an acute disc, especially if it's extruded. And then finally, injection therapy, which I'm generally a proponent for, particularly for a disc herniation or bad stenosis. Try the corticosteroids unless there's an indication to not do that. I certainly don't think it hurts. I have plenty of patients, absolutely, they know someone who had them and it didn't work for them, and they have a back problem, so it's not going to work for them. And I say the same thing to all of them. They have a problem, and you have a problem. And they have a car, and you have a car. What's the likelihood that you have the same car? The back has so many different problems. You can't assume that your neighbor's back problem that was fixed by the chiropractor is going to be the same thing as your back problem, even if you think you have the same symptoms. Maybe, but it's not likely. Okay? So I always say try those shots unless there's a reason otherwise, and only your physician can tell you that. The operative treatment, there's many things we can do for these problems. We're kind of lumping everything in here. So I'm just giving you guys a broad overview. You won't be able to perform the operation after this talk, okay? But you'll learn a little bit more about your back. what are called fenestrated procedures. This is what's called the laminotomy, a microscopic discectomy. It just means we make a little hole in the bone. Why do we make a hole in the bone? Most disc herniations happen in this tube. God did something very smart. He put all of our important structures and he surrounded them with bone. The rib cage protects our very important heart and lungs. The skull protects our very important brain. And our nerves are protected by bone. So the fenestrated procedure simply means we make a hole in the bone. That's where the disc herniations are. That's typically where the bone spurs and the pinching is. And that's what's called the laminotomy. Sometimes we have to take down a portion of the joint. The other thing that we used to do, or we still do, is called the laminectomy. That's a bigger hole. And I'm going to show you what that looks like here in a second. And then we developed some of these other procedures called laminoplasty and minimally invasive surgery, which are a more focused type procedure as far as making these holes and making smaller incisions. So this is what a laminectomy is. This is looking at the back like this. And a laminectomy simply means this portion of this is the back. You can feel these bones in the back in most of us. All we do essentially is take this bone off. So the tube is crowded and we take off the roof. If this roof was down here, if I take it off, I could stand up and be happy. That's the way I think about it. That's a laminectomy. They've been doing that procedure for 60 years and it can work. It's worked well for a lot of people. The problem is you got to make a big incision, you can see, and you have to take off some of these important structures. Okay? Sometimes it's absolutely necessary. And looking at you from the axial cut, you can see it's this bone that needs to be taken off. Sometimes there's no avoiding this, but in some patients I think there is. That old way is like throwing the grenade in there, okay? You strip a lot of muscle down. That muscle is never quite the same. A lot of surgical trauma, blood loss, and so forth. The minimally invasive spine surgery looks for an alternative treatment. And probably the first known device was this device called this Inter-Spinous process device. That didn't work for everything, but it worked for your run-of-the-mill older patient stenosis. Might have worked, I should say. And then that being very at least successful for some period of time has led to more what I call tube surgery. I think that's the classic minimally invasive surgery. The small incisions done through the tube, the microscope, and we'll go over some of the benefits of that. The diagnoses that can be treated here are disc herniations and stenosis and spondylolisthesis. The benefits of such procedures are less pain, less bleeding, shorter hospitalization. I've certainly found fewer infections because there's less trauma to the body. Improved results, certainly from an earlier standpoint, and then earlier return to function if you're an appropriate candidate. This Inter-Spinous process device was interesting, and I wanted to bring it up because I think it's going to help illustrate one of the points. It's largely fallen out of favor for a variety of reasons because I don't think it worked for the long term. But some of you may have heard of a device called the X-stop. And I still have some of my older patients that will come in asking about the X-stop. And what this did was it took advantage, if you had this pinching, that people felt better if they leaned forward. Okay? So we have these spinous processes back here. And if you just separated them, it would be just like at that one segment you were leaning forward. So surgeons thought it'd be a great idea if we stuck something in there to hold that there. And they were right in theory. You can see the illustration here, that if you had this little pinching at this area, if you put some block in there, it would kind of straighten things out as far as your nerves. And for certain patients with mild to moderate stenosis, this did work. And this is what that used to look like. If you ever heard of an X-stop, this is an example of an X-stop. There were other proprietary names for it, but this is essentially what it was. And you can see we're talking about these holes, and what these lines are showing is how much these holes actually increase from preoperative to postoperative when you put that block back there. It hopefully illustrates the idea of just making these holes bigger. That's all I do. I make the holes bigger. Okay? And there's a 2-level example of someone. You can see how much bigger that those holes got within the foramen. But again, that's part largely fallen out of favor. I'm showing you more from a historical perspective, and that patients often still come and ask for this. What about minimally invasive surgery? What this is we make a small incision. We use a lot of X-ray during this procedure to localize and create a focused surgical corridor. Okay? We don't want to make a big incision like you saw there with the laminectomies. We want to be focused like a sniper. And we use X-rays in the operating room. We make the appropriate incisions. And what will end up happening is we find the area where we want to operate. We put successive dilators through the skin and soft tissue, which would include the muscle, until we get it big enough where we can put a tube in. The tube obviously is smaller than your standard incision in most cases. Once we have that, you can see this is an X-ray of that tube. Once we have that, we can rotor or make that hole a little bit bigger. This is an example of that in the operating room. That's me. And you can see using this technique and different types of instruments, using an operative microscope to keep everything nice and safe, that we can go ahead and address things. This happens to be a disc herniation, by the way. You can see how soft and bulbous that is. We can take out a chunk of disc that might be pressing on a nerve. That's a real disc herniation from one of the operations that I did. And those patients do quite well. Other things that we can do through this small tube is take out what's called a subtotal discectomy if we want to knit the bones together. Some of you might know that as a fusion. We can, through that tube, create an environment where not only can we get the pressure off the nerves, but we can also create an environment where those bones don't move anymore. Okay, we talked about the patients that have spondylolisthesis where the bones are already starting to move. And sometimes when we rotor out the holes, it starts to fall even more, so we have to knit the bones together in that particular situation. And that also can be done through a tube. So the old way, this is what this looks like. This is conventional spine surgery right here. It's called an open procedure. And that would be a bigger incision and some muscle stripping. And the new way involves a much smaller incision, again, if you're the appropriate candidate. And some of those people would literally go home with the Band-Aid. So the old way, grenade, I came up with this, guys. It's real fancy, all by myself. See that? I did all that, all by myself. It is good. Thank you. So the pros of using these tubular retractors and so forth, I think there's certainly the benefits of minimally invasive surgery. The less bleeding, less pain, shorter hospitalization and so forth. The cons, you can't help everybody with it. And I don't try to help everybody with a small incision that's going to produce inadequate results. Some people, the pinching is too great, where it's just not a good idea to do it through the small incisions. How do I know? I've done it. I've done thousands of procedures through a tube. And I'll be the first one to admit, there are some you look back and you say, that was a bad idea. Took too long, didn't go as well as you wanted it to go. Didn't hurt anybody. You hurt my neck. I was there for a long time. And so there are some things that you can't let technology trump reason. And there are some things that are simply better with an open procedure. Okay? So there are some limited indications. Sometimes there's just too many levels involved. I've done minimally invasive surgery that involved 5 levels of the back, L1 to S1. Okay? In some patients, that's okay. In other patients, they simply don't have the body habitus. The deformity is too great. There's some reason why it doesn't make a lot of sense. Okay? Maybe you have a bad scoliosis. And I love doing scoliosis surgery, minimally invasive. But sometimes it just because you can do something doesn't mean you should do something. And that, I have to say, comes from experience. And there are some people who I just say, I don't think it's a good idea for you. And then you're not getting any other surgery that's different than what the standard of care would be, that might be found in any textbook that any spine surgeon might read on a regular basis. You're getting what is the standard of care. This is slightly different than that. And a lot of surgeons don't do this in the area because there is a steep learning curve. I certainly can tell you it took me a long time to become very proficient at this, but fortunately I've been doing this operation for what I consider a long time, and have done thousands of procedures through the tube. So for me, it's not that big of a deal, but if you're used to doing surgery one way and it takes you an hour and a half to do an operation and you're having what you consider reasonable results, why would you want to change to an operation that might take you 4 or 5 hours for your first 10 or 15? As a surgeon, that's not a really big sell. Okay? Who would want to do that? You have to be willing to struggle through those first cases. And I hate to be so candid about it, but yeah, there's surgeries are struggles. We're surgeons, we're human beings. And sometimes the new stuff takes a little bit longer. Okay? But generally speaking, I certainly feel like I have a good idea of what's going to work, when it's going to work, and why we should do it one way or the other. And it really comes from experience. So I think one of the great things about minimally invasive surgery is this hospitalization. With an MIS decompression, sometimes you can go home the same day. Even an MIS fusion, worst case scenario, a 1 to 2 day hospitalization versus the old way. I'll consider it the old way. It's probably a misnomer. I shouldn't call it the old way. I'll call it the standard way. Oftentimes a 4 or 5 day hospitalization. You get up a lot faster, moving around. You need less pain medication. And I think it improves function, decreased leg and back pain. But I also do open procedures, and there's no question, it works. With the right operation, the right patient, the right indications, we get great results with the open procedure as well. Okay? And that's what I got for you. I'd like to open it up for a few questions. I do have some place to be, but you guys came, and I really appreciate you coming to the talk. And usually patients have questions. They're never satisfied just with what you say. So I'd like to open it up for a few questions to myself or on your way out. My nurse practitioner, Jennifer, she knows everything that I know. She loves to answer questions, especially phone calls.
Nice way to put it on her, Doc.
That's right, yeah. That's why she gets paid the big bucks. That's why she's here. She's earning her nickels. But what questions do you have for me, either about a spine problem or minimally invasive surgery? Yes, ma'am.
I know I have more than one problem. I already know it. I'm a patient here at Coordinated Health.
Is that a problem, or? That's your first problem,
They've
right?
been helping me, okay?
Perfect. That's what we want to hear.
I am going to need another hip, though, and I do need another hip.
Yes, ma'am.
But I also got a bad back problem. And I have spurs. I saw them on the CAT scan. Do they ever get to a point where they need to be removed, or does anybody ever remove those? Do they have to be removed?
You're talking about spurs in the back?
Yeah, I saw them.
First, you need to be evaluated. Generally speaking, I'm going to paint in broad brushstrokes from my practice. I don't know anything about you per se. But generally speaking, everybody who's over the age of 50 or 60 years old is going to have spurs. Most of them are not symptomatic. For whatever reason, some of them either get too big or you do something to exacerbate a problem, and some of them can become symptomatic. But as long as everything works and you can get along, I'm going to make a general statement and say they certainly don't have to be removed. It's part of the normal aging process. If you didn't have bone spurs and had both hips replaced, which means for whatever reason you probably form more arthritis than the rest of us, I'd be surprised if your back looked normal. So it's normal for you, but I don't think just a bone spur has to be removed.
Okay. They usually don't cause I have other problems with my back, too.
Of course.
Big stenosis.
And you bring up a good point, because a lot of people will say, we talked about these problems, you're 60 years old and you have 5 or 10 problems. Do I get my hip first? Do I get my knee first? That's a complicated issue that should be discussed by both the spine surgeon and your orthopedist. Which one gets done first? Generally speaking, and again, broad brushstrokes, I don't know anybody's specific situation, I say get the hip or the knee done first, unless the back problem would prevent you from performing the rehab for the hip and the knee surgery. That's just my feeling.
Yeah. I have Dr. Scarpino, and I did get the left one done in December. and he strongly suggested to me, he knows I have back problems, but that I get the hip. And you know what, he was right. I mean, I didn't walk in here looking too great, but I am a lot better off than I was.
He's a great doctor.
Yeah, and I think when I get the left one done, I will standing and straighter. I can't.
And that's a possibility as well.
And I don't know what I'll have to do with the back after that.
Maybe you've compensated so much because of the bad hip that in fact it's aggravating the back. Because our hip and our knee replacements, I think they're simpler than anything in the back. I know they are. They've come a lot further. It's a simpler joint. You only have one left knee and one right knee. We've got how many joints in the back? We can't replace all of them, but it's a great operation. I truly feel it's one of the best operations out there as far as decreasing your pain and improving your function. That's why I so readily tell patients, get your hip or your knee done. It's so routine. If that's what's holding you back, get that done first. Unless it's so much pain coming from your back, you couldn't do that knee rehab, especially for knees. The rehab is so critical for a good outcome. You got to get in that situation, I'd say get the back done first. Yes?
I have a pacemaker.
Yes, my favorite. Are you on a blood thinner as well?
No.
Oh, that's good. I like you more.
And I know it's L4 and L5.
Uh-huh.
What about surgery with a pacemaker?
We do it all the time. I don't love it. Usually because people who are on pacemakers are also on a blood thinner, and that increases the possibility of some type of catastrophic surgical complication. So I don't love it. But the other issue is folks with pacemakers can't get MRIs. And I hate that. And here's why. This is the way I think about it. I think that an MRI can really pick up 99% of your problem. That's good. We could see lots of stuff, okay? A CAT scan, I think it's 70% of the pinching is seen, which means we're operating with 70% of the information. If I give you a road map to my house, that MRI, by the way, is a road map to your back. If I gave you a road map to my house, but I'm going to leave out 30% of the streets, you might be pretty confused. You might not even find your way there. And that's the issue we have. That's the issue that I have with a CAT scan. So firstly, I need to tell you that. And then we have to take a good history, and we have to we got to see what we can see. Some CAT scans are better than others, and insofar as quality, you could see some more stuff. Sometimes with people with CAT scans, I think surgeons are a little bit more aggressive because they're afraid of missing something because they don't have all the information. So I think you can be helped. You're just more complicated than the person sitting next to you. That's it. It's not a reason not to have surgery. You're just difficult, as my mom would say.
There's one in every crowd.
There you are. I mean, there's not one. Not here. Yes, ma'am.
What is a rhizotomy and how successful is it?
You know, I don't do rhizotomies. Dr. Goldberg in this office does rhizotomies, and Dr. Stoll and Dr. Cooch and Dr. Mazza within Coordinated Health all do rhizotomies. But here's the idea. There are small nerves that go to the facet joints, here and here and here. Those nerves are for pain. They're called the medial branches. Okay, so you may have heard it as a medial branch block. And what happens is, if you have pain coming from arthritis in the facet joint, which is typically pain when you go into extension. Now, there are other things that cause pain that go into extension, but back pain when you go into extension and you grind or load those facet joints, you may benefit from a rhizotomy. And it will burn the small nerves. You're not burning these big ones. Your foot won't work if you burn this one. But the small nerves that just go to the joint. And if you burn those nerves, and by the way, they're just guessing where it is, putting a probe based on their understanding of anatomy and using the x-ray. And they put little probes on there and they heat the probe up to a certain temperature and they just hope that you have normal anatomy like we learned about in medical school, and they will burn those nerves. They come back. That's the problem with rhizotomies. It's not a permanent solution. That's the good news and the bad news. You don't want something totally permanent, but the bad news is if it gives you relief, it comes back. Hopefully, and in my experience, 6 to 12 months, best case scenario for those nerves, assuming that your pathology is only coming from the facet joint. Make sense? Yeah, if you have a rhizotomy. Yes, sir, did you have a question?
Yes, I have your typical herniated disc at 405. Saw it on an MRI. Started about late December, and we're going into the 3rd month now. And conventional therapy, I had a epidural done. I had some relief from that, and actually I've gotten a lot of relief from chiropractor, to be honest with you. Releasing the pressure.
I love our chiropractors, so don't think that just because I went to medical school and I'm a surgeon that I don't like chiropractors. I think chiropractors have a tremendous amount to offer for neck and back. No question.
But I've been getting relief, but it's good days, bad days, good days, bad days, and it'll come back and be very painful down the leg, the whole sciatica thing. And my question is, when do you determine that surgery should be done? It's more of a solution with surgery than it is with any of the conventional therapies. And when do you determine?
It's a great question. My patients always want me to tell them what to do. I don't want to tell anybody what to do. It doesn't work at home. Believe me, it doesn't work at home. And it's not going to work here either. So here's what I do. And this is just my style. I'll tell you what's in the book. A book is written by lots of very smart people. They come up with an idea of this is how to treat this. And then together we go through it and decide, do you fall into one of the categories? So the reasons, I could throw up your MRI and in 5 seconds I can tell you I'm not operating on this. Okay, you're not saying the right thing. It's not going to make sense. So there's a lot of variables. But the book answer is this. We operate on the disc with failure of non-operative treatment for 6 to 12 weeks. Some say 6, some say 12. Let's just say 12. Any functional deficit. What that means is you can't move your foot up, you can't climb stairs because you have weakness. That's a good reason to operate. Incapacitating pain, which is a bit subjective. What hurts me, I don't know what incapacitating means, but I know it when I see it. I don't know, incapacitating means that you can't go out and play golf. That would be incapacitating for you if you love to play golf, right? But right now, you look like you're fine. It doesn't look like incapacitating to me. But if you have a narcotic requirement and you can't do the things you want to do, maybe that's incapacitating for you. Any progressive numbness, tingling, or weakness. So yesterday, everything worked great. Today, now the foot is numb, or something like that. Any bowel or bladder dysfunction. And I'm hesitant to say that to a group full of people, because everybody's going to say they can't go to the bathroom tomorrow and they have to see me. I've seen that a handful of times. None of you have it, okay? Let me just say that right now. Those are the simple things. So I would say that to you in the office like I'm saying to you now and say, which one do you have? If you can't say yes to any of those things, then you don't need an operation. That's simple stuff. And that way we make the decision together.
So what do? You deal with levels of pain for years?
So if you hit that 3 or 4 month mark and you're sick and tired of being sick and tired, then we look and see if you say the right thing and we see the right thing on the MRI. There's plenty of literature to suggest that patients who have operations earlier with their pain do better than those who have waited. And that's my experience as well in the office. That doesn't mean we push people to have operations after a week. It means that patients who have had chronic back pain for 6 years don't do as well as if you had back pain for a week. It's that simple, and it makes sense. Okay? If you had a horribly pinched nerve that was flat and you were writhing in pain and it went on for 6 months, looking back, it would have been better to do that after a week. The literature is quite clear that those patients who have an acute disc herniation, assuming yours is acute and looks horrible and everything else is in line, that you will get better fastest with an operation. Not 4 months of chiropractic care and injections and all this other treatment. But no one wants a back operation. I mean, who wants a back operation? So I would do everything that you're doing unless you fall into one of those categories.
How long is an MRI good for before you need to do it?
I'm going to say it depends. Standard, run-of-the-mill stenosis, if we were considering an operation, so 65-year-old female, classic stenosis, seeing for the first time. If I'm not going to operate and there's no change in symptoms, there's no real reason to update it. If we were going to operate, I need that roadmap. I don't want the roadmap from 5 years ago. That's the best chance, is that first time you're going in for a back operation. For a disc herniation, I usually say 6 months. But it depends. If it's a big extruded fragment, if the character or quality has changed, we have these wonderful tests, these MRIs, the quality of which is fantastic. Generally, closed MRI, not an open MRI. Those are not so good. But they can provide us a wealth of information to help you get better. And so somewhere, I'm going to say 6 months, but that may be.
Anything about the opening after you cut away the bone?
It depends on where the disc herniation is. So
I'm sorry, what was this question?
something about the opening when you take out the disc herniation. Oh, so the disc, the hole itself. And the answer is no. There is a hole. Forget about that. If it's in a textbook, we can talk about it. But I told you, the fairy dust and the lasers, we're not talking about that. Okay? I put them in the same category. Okay? But so there's a hole. The disc, for a disc to herniate, it has to make a hole. So your body put a hole in it. There's nothing I can stuff in there. People have tried plugs. They tried sewing it up. In my mind, none of that has conclusively shown that it decreases your pain or that it decreases the risk of a recurrent disc herniation. But it has increased the operative time and the blood loss and the chance for a spinal fluid leak and all these other things. So I don't close the hole. No, I don't. No one does in this area. I don't know anybody who's not working on a study to try to prove something that does that.
I never had an MRI, but I got 2 artificial knees and an artificial hip.
It's not a contraindication. Sometimes they like to wait 3 or 4 months.
The metal doesn't affect it?
It should be fine. I'm going to make a broad statement. It should be fine. I don't know what's in your knee, but it should be fine. Yes, ma'am.
My son is 38, and he lives in New York City. He's been diagnosed with a herniated disc, and the doctor/surgeon with whom he's been dealing has recommended surgery, and the plan would be he would go through the front of
Is it neck or back?
Neck.
Mm-hmm.
Yeah, through the front of the neck. And the doctor has also said that he thinks that if Doug doesn't do it now, that or waits, that it would get worse in a few years, et cetera, et cetera.
Mm-hmm.
With that little limited bit of information, would you recommend that, would this doctor comment on minimally invasive surgery, do you think, or should Doug look into that separately before he does anything?
So I'm going to make some things. First of all, for a neck operation going through the front, standard of care.
Standard.
Absolutely.
Okay.
I love that operation.
Oh, all right.
I'm going to do that operation tomorrow.
Okay.
If I didn't have to look at another back pain patient, all I could do is neck, I would do it all day long.
So that's a good thing.
Oh, I love it.
Oh, good.
That's great.
And the fact that this doctor thinks that's workable is a good thing.
Yeah, I mean, that's the way it is. I mean, I think that neck operations work very well from the front. It doesn't seem that way to the average person, but they work quite well from the front. So that's the first thing. Some people are candidates for a procedure that I can do in the back with the tube. I have my doubts with a 38-year-old. It generally works in younger people, generally with a soft disc herniation.
The front does, you're referring to.
I'm talking about the minimally invasive posterior procedure. But the front procedure, I mean, that sounds very reasonable. But I think you can apply what we've talked about when I gave the indications for the lumbar discectomy to this situation as well. But I don't have the opportunity to look at the MRI or anything like that. But failure of non-operative treatment, incapacitating pain, progressive numbness, tingling, or weakness, bowel or bladder dysfunction. Now, he may have other problems, spinal cord impingement and so forth, but at the end of the day, you have to trust your doctor and hope that they're just doing the right thing and they want to do the right operation. And if you have a disagreement about it and you're worried about it, a second opinion, while it's time-consuming and annoying and stuff like that, I don't think there's certainly no harm to that if it makes mom sleep better at
And
night.
I'm sorry, you were referring to the minimally invasive tube approach is good
From the
for
back.
38-year-olds? Is that what
It
you're
may
saying?
not work. I don't know. I haven't
it
looked
may
at it.
not.
It may
Yeah,
not, because
right.
you have to look at. That's when it's a very specific diagnosis in my hands. Again, the worst thing, one of the worst thing we can do is, what if we had an operation and you signed the waiver to have this done and you didn't get the relief you were seeking treatment for? That doesn't help anybody. So I'm not interested in performing those kinds of operations. And so you have to see what the best one. But oftentimes it's very common to go through the neck.
Thank you.
That sounds right.